Okay, I think we're at the top of the hour. So welcome everyone. My name is Christine Torjeson. I'm at FHI 360, and I welcome you to this session of the Global PrEP Learning Network, which is hosted through the EPIC and RISE projects through a collaboration called CHOICE. And today we are going to talk about rethinking the use of risk assessment tools for PrEP. Which is a challenging topic, and I'm really looking forward to diving in deeper with some of the ideas from our speakers and panelists and having a good discussion. Next slide, please. Okay, so this is an overview of what we're going to talk about today. We have an overview of the issues from Rachel Bagley. From WHO, we have a presentation on risk conversations and operationalizing risk assessments from Andy Lambert with the EPIC project. We'll hear from Joseph Marungu on Zimbabwe's experience with risk assessments, and then have a panel discussion with three national policymakers from Eswatini, Zimbabwe, and South Africa. Next slide, please. So this is just an introduction to our speakers today. Rachel Bagley is the team lead for testing, prevention, and populations in the global HIV, hepatitis, and STI programs at the WHO, and her work includes supporting global normative guidance on prevention, including PrEP. Andy Lambert is a senior technical advisor for key populations and priority populations for the FHI 360 EPIC and linkages programs, and he has over 20 years of experience in HIV programming, from vaccines to microbicides research to service delivery. Next slide, please. Joseph Marungu is a senior technical consultant for Pangaea Zimbabwe AIDS Trust, and he collaborates frequently with the Ministry of Health and Child Care to work on introduction and scale-up of oral PrEP. Hasina Subadar is a technical advisor who supports the National Department of Health in South Africa and does a lot of the work related to implementation of PrEP, as well as managing the She Conquers campaign. Next slide, please. Gertrude Nkube works with the National HIV Prevention. She is the National HIV Prevention Coordinator for the Zimbabwe Ministry of Health and Child Care, and has led national combination HIV prevention programming for the general population for over 10 years, and spearheaded the introduction of new products and new interventions such as VMMC and PrEP in Zimbabwe. And Cindy Matse is responsible for technical leadership and coordination for the Eswatini National AIDS Program. She facilitates the development of policies and plans and designs programs for key POPs and PrEP programs in Eswatini. Next slide. So we're very thankful to have all of these excellent speakers with us. We also have some additional folks in our panelist room who may also jump into the conversation. We have 152 people on the line so far, so welcome to all of you. Because of the number of people, we are not, all of the attendees are muted, but we do want to have an active discussion in the chat. So I just want to remind you, in order for everyone to see your questions and comments, you need to hit the little arrow and select all panelists and attendees, and then everyone will be able to see your questions and comments. Next slide, please. Okay, so we're going to dive right in. I'm going to pass this over to Rachel Bagley from WHO, and she's going to give us an overview of the issues. Thank you, Rachel.
Thank you very much, Christine. It's really great to be here. I'll turn my video off and continue. So certainly risk assessments for PrEP, this is something that we at WHO have been thinking about and vacillating on for ever since we started our work recommending PrEP. Next slide. So as I'm sure everyone knows, when we developed our guidelines, we really said there were just three things you had to, made PrEP something we should offer: negative status, not not having had a very recent exposure or having acute signs of acute HIV infection, and to be at substantial risk. Now, how do you find somebody at substantial risk? And that's why we're really talking about screening tools and substantial risk. You know, at the time and this was back in 2015. You know, because PrEP is expensive, we really wanted to look at it in a way that would be cost effective, and so we did some really back of the envelope calculations and thought, you know, if that person was an HIV risk of about 3%, then PrEP could be cost effective. Next slide. So why risk assessment? As I say, countries, and again, as we were thinking about introducing PrEP, discussing with countries, everyone said, well, this is hugely expensive. We can't possibly offer it to everyone. So we need to think about prioritizing it and making it cost effective. And, you know, people were also worried about the harms of giving PrEP to a lot of people at very low risk who might have adverse events for themselves or adverse for infants. And so we really think about this number needed to prevent. How many people is it acceptable to give PrEP to in order to prevent one HIV infection? Next slide. And we've always been really keen on the idea that one of the sort of overriding tenets of who should have PrEP is people who want it. And of course, people who want it need to understand and recognize their risk. And this is some work from Rwanda looking at risk by age and sex. And of course, it's not surprising, you know, men express or their worries about risk at a higher rate than women, and younger women at a less express their risks less than older women. Next slide. And although this, you know, this does relate quite well to when people initiate PrEP, it's not absolutely perfect. Next slide. So are we getting this right? And when I was preparing these slides late at night, I hadn't really looked at the agenda to see that Hasina was there. So the next two slides relate to some thinking about South Africa. And of course, Hasina leads all the work there. So maybe she can come in and tell me I've got this all wrong. But when I was looking at what was happening in South Africa, I thought this was really, really telling. You know, for sex workers, if you look at the offer of PrEP between the yellow arrows there from women who are negative to an offer, it's a small gap. Whereas you look at you know, young women in the university population, there's a much greater gap there between being negative and being offered PrEP. And what makes that decision? Is that appropriate? And maybe it really is. Next slide. And I think the reason for this is, and again, these figures are really back of the envelope. They're probably highly inaccurate, but I was just sort of estimating there's probably around 7 million girls in South Africa, probably about 5 million who are HIV negative, and of those probably, you know, 4 million sexually active. And that's a hugely heterogeneous population. Prevalence varies enormously, incidence varies right in, you know, from region to region. But we do know that there are groups within South Africa and any other country in East and Southern Africa where you really do have much higher incidence. So focusing PrEP offer in those sites is obviously the first way to go. And then you have these overlapping risks of having an STI and of being in having sex work. And these factors all overlap when you're thinking about giving PrEP. Next slide. But why would we not offer assessments? And I think, you know, for many of us who are old, we go back to those early days when we had all sorts of questionnaires before we asked people about having an HIV test, and they were long and laborious. And, as providers, we really hated doing them. We felt sometimes we'd miss questions because we felt, a bit embarrassed about giving them. So are these really, really well provided in by providers? And of course, clients, and we were discussing, we had a meeting on risk assessment just at the end of last year. And I remember one person saying, oh, well, people aren't truthful. I don't think it's not that they're not truthful, it's why should they answer these questions that you have to jump through hoops to answer if you want PrEP. I don't necessarily want to tell everybody about my sex life. And also, if I don't answer those questions, then I'm going to be excluded from services. Next slide. And then there are two types of risk assessments, those to screen in and those to screen out. To screen in, these are sort of prompts to offer, potentially in a large heterogeneous population. These are prompts that might bring you to think, right, I should be offering somebody PrEP. Screening out is when you really are thinking more of rationing PrEP and deciding who can jump through that hoop. Next slide. So what do we want for a screening tool to be really effective? We need it to be highly sensitive. So we don't want to miss people who could benefit from PrEP, but we also want it to be specific. So we don't want that tool to screen in lots of people who wouldn't benefit from PrEP. So next slide. So as I said, they must be accurate. We must also make sure that they're validated within that context. Next slide. They must be reliable and they must be feasible. So long lists of multiple questions is really out of the question. Next slide. So when we look at the tools, and I could have talked about this for hours upon hours, because there are multiple tools and there have been multiple assessments of them. And frankly, it's a very, very mixed picture. And I just wanted to highlight this, this nice paper that came out recently from China. And they were looking at screening tools from Europe, Korea, South Africa, Taiwan, UK, US, and WHO. And frankly, they were all rubbish. They really weren't any better than random allocation for assessing who could benefit most from PrEP. Next slide. And similarly, slide here, this is again a recent study looking at the performance of risk scores, the voice risk score, and again you can see there's if you look there, the area under the curve is really not sufficient to make this tool useful, and the authors there concluded that the current risk scores, risk tools for South Africa were not fit for purpose. Next slide. So where are we at WHO thinking about risk tools? We are really a bit sitting on the fence. I think, there is so much mixed evidence. There are so many drawbacks. And I think, our thinking is, if it's going to be a prompt in for PrEP, that's probably helpful. But a prompt out for not offering PrEP is probably something we would want to discourage. And I'll give you a little anecdote here. In Australia, where they have a highly successful PrEP program for MSM, to get on that program, you had to tick the boxes. And very soon, it became obvious in the MSM population, they knew exactly what they would have to answer if they wanted PrEP. So they would just answer it. And they found that virtually no one who came in wanting PrEP didn't fill all those criteria. So should we be thinking now more about not having screening tools, not having risk screening tools, but more about something that would help us prompt, help us nudge, help us with that PrEP conversation. So really my takeaway is, do we do away with these risk assessments? Do we modify them to make a much less prescriptive approach? Do we think much more about a PrEP conversation tool? Or is there something else we would be doing? We certainly, you know, don't have those answers at WHO yet. And I think it would be really great to you know, have much more understanding from communities, mentors, so that we could come, you know, to some sensible way forward to support people to take PrEP when it would benefit them, without making it overwhelming, particularly when you've got huge populations, huge heterogeneous populations, such as for adolescent girls and young women. Thank you.
That was terrific, Rachel. Thank you. And I think that is the key question we want to explore, and we'll hear some more about some other aspects of risk assessment in the upcoming talks. But I also want to encourage, you know, we have over 230 people on this call, many of whom probably engage with risk assessments for PrEP in their daily work. And so we also welcome your comments on thoughts on these questions that Rachel is raising. So without further ado, I will move over to Andy Lambert.
Great. Hi, everyone. Thanks for having me here today. I'm going to be speaking, you know, thank you, Rachel, for a wonderful intro that really, I think, leads well into what I'll be talking about. And that is, you know, risk conversations and really operationalizing risk assessments within the context of programs. The when, the why, and the how. Next slide, please. But first of all, I really just want to give a strong appreciation and thank you really to the implementers and organizations, CBOs, that are all really struggling and working hard to figure this all out. It's an intense time of COVID-19, and, you know, we're really not only working to end this HIV pandemic, but now, you know, all of us collectively, I think in this room, are really working to end the dual pandemics at the same time. But I just want to give special thanks to the folks who have really been a part of this presentation, and the forward thinkers, Engagement's Health from South Africa, PAC Lesotho, and the FHI 360 technical team, specifically Dorka Boy, you've really been a part of really unpacking risk assessments and as it relates to PrEP. Next slide, please. So just a little bit of context around the context and the challenges of operationalizing prevention, PrEP, and treatment ART programs at the same time. You know, the program demands are high. You know, a lot of the programs, countries, or PEPFAR funded, Global Fund, large target. So we're really being asked to find really high numbers of positives, which comes with that the kind of the work and the resources to get the positives on ART, adherence, viral load suppression, and maintenance, the treatment as prevention approach. And then keeping HIV negative individuals negative, right? So a larger prevention in the larger sense, keeping individuals from getting infected, where specifically our targets are very much around oral PrEP. And high HIV positive case findings, over testing and not testing the right people. We know with this heavy treatment focus, the targets seem to take away from the broader prevention efforts and messages in many ways. There are country guidelines that really set, for example, with KPOPs, testing frequency at 2 to 3 months, which really stifles and limits our ability to be more efficient and more targeted in reaching those more at risk and need. And then the larger cohorts that are growing when we have focused programs with populations, we really have to ask the question, are we repeat testing the same people over and over again? Or have we saturated basically any subpopulation we're working with? So these are reasons for really thinking about how to hone in on finding the highest risk. As we know, we really moved from a generalized to a localized and a more targeted approach to finding new positives and to what I call a needle in a haystack approach in some of the countries we work in, where it is getting more and more difficult to really identify those new positives. And so we've really honed in our approaches instead of this blanket reach to more targeted testing around risk network referral approaches, targeted testing at specific risk locations, index testing, etc. And, seemingly it seems as if there's an entire focus on just, as some community members call it, hunting down positives. We're getting reactions from certain communities where they're really feeling like they're being left out of services in whatever, how they deem that, as we start to hone in and select a higher risk population. And most countries, just to talk about PrEP now, really only have one option for PrEP, and that's oral daily PrEP right now. So we have these huge targets that are based on a proportion of HIV negatives without any real further understanding about the risk or ready, willing, and able to use of this specific PrEP modality. So, where are the PrEP options that are available, but where there are PrEP options available, other ones, but where are the guidelines that really follow thereafter? Next slide, please. So when we're really talking about exposure, we really think about it of, different types of exposure risks. Associations with HIV risks really around the primary, and that's condomless sex with a range of other risk multipliers, risk reducers, and really thinking about how we ask questions that kind of get around the social desirability of the answer to have an honest conversation. And then what are the secondary risks, the vulnerabilities that may lead to the condomless sex, mental health issues, gender-based violence, intergenerational sex, etc. ART is really about the past HIV exposure, find the new positives, and then the whole downward treatment and care cascade. PrEP is really about the potential future exposure. So really understanding risk and people understanding their risk and or their vulnerabilities is what we really need to get better at. And I have some examples, next slide, of how we think to do that. I will go through these quickly, but risk assessment tools on the ground, as Rachel just said, really need to be simple. Some kind of skip pattern, easy to kind of track and tick when someone's at some elevated priority, as we would call it in our small implementation study in Lesotho. That includes a section really where there's an instruction of an education of a component of a dialogue that really helps guide how to ask, discuss, and interpret that question, and then has some kind of PrEP discussions within it initially. Next slide. So one really important point when we're really talking about primary exposure risks, and that's really trying to have that open and honest conversation around condomless sex. And, we've really run this past a lot of different groups, and this specifically with MSM, really looking at how we ask the question and take some of the social desirability off of the person. And so not making it about, I didn't use the condom, but the condom wasn't used. So really changing the way we ask a question in a series of actions that could happen that doesn't necessarily put the blame on the person, but allows them to say, yes, this happened. But to go further and try to further risk segment with an MSM population specifically, to really try to assess, what is the actual exposure risk for anal sex, receptive, insertive, both, or refuse to answer. And refuse to answer often as a proxy with masculinity norms around some type of receptive sex. Next slide, please. So the results of it were really powerful. 709 MSM were eligible for testing. We screened them, tested them systematically with HIV self-testing kits. We looked at the data, cleaned it, validated it in terms of clean data, and really looked at what we saw. And we did clearly see a differentiation. Zero new case findings in the lower group, with 89% of HIV case findings in what we would call a high risk category. Ages over 30 were 82% of the infections, but under 30, we really, and if you see on the right, started unpacking a really interesting risk around intergenerational sex. We know this holds true for adolescent girls and young women, but for MSM, we think there's something here that can really help us further segment. But ultimately, at the end, condom use, we were able to really capture that people 66% of the 709 MSM reported condomless sex. So 27 out of 28 positives really came from this group. And we really think we were able to tap into a way of asking that question better to really have a dialogue and conversation. Next slide, please. So the approach is really about, risk segmenting to reach this higher risk population with all these positive targets, but being more efficient with that while we're increasing case finding rates. But what that does is it also creates an increased pool of higher risk HIV negatives. And we really think of both for PrEP and ART a screen out opt-in approach. So for lower exposure risk individuals, a test, if desired, isn't denied, but it isn't necessarily kind of actively offered. Provide PrEP if asked, but not actively offered as well. The screen in opt-out approach is really high exposure individuals, and the opt-out is having that conversation more around what is PrEP, are you ready, willing, and able to do it as it needs to be done to be protective. Next slide. So some interesting work that's been done by the Engagement's health program has really been asking the question around if I'm negative and at exposure risk, am I really ready, willing, and or able to start oral PrEP? And, not willing being about client doesn't really think PrEP is important or needed for them, and not able being that it doesn't fit their lifestyle or they can't commit to taking a pill a day. Next slide, please. And some really interesting findings that we've seen come out of this. We compared PrEP initiation uptake between a high and low risk MSM population based more on segmented exposure later in the months of November, December. But from July to September, we really looked at high risk segmentation based solely on the criteria that exists now. They're purely MSM, they report anal sex, and and that's it. That's really, and they're negative. And that really is where we offered. So it was a screen in opt-out approach for all MSM who are negative, basically. And what we see in pink is that in the lower risk, as we've seen in the diagram that Rachel presented, that risk is a conversation, and people may be self-selecting out based upon their risk profile. And if you see, it still is higher in the higher risk group. However, in then October to December, we started screening out lower risk and not referring for. And then later in November, December, changed the risk categorization to add condomless sex exposure as the primary risk. And in doing that, we were really able to see that 43% of the group shifted into the lower category. 59% of new high-risk individuals who were categorized as high risk initiated. That was a jump from the prior months. And of those who were ready, willing, and able, 84% actually started PrEP, where we see in December 100% ready, willing, and able to start. So really gauging where people are. And we hope then that we're further tracking to see if the ready, willing, and able group actually has a better PrEP current and use over time. Next slide, please. But I just want to make a focus here. We don't talk, I mentioned secondary exposure risks and assessments with PrEP, but really what we're looking at right now is this primary exposure, condomless sex, and these types of risk elements. But, of note, we really need to do more work on screening for secondary risks, talking about them, and identifying opportunities where we can have these conversations and look at how secondary risks. How do we talk about PrEP in the context of someone who just experiences violence but hasn't really talked about any current past exposure? So that's just something I think that needs to be more unpacked as we move forward. Next slide. And PrEP targets are unrealistic with only, with only oral PrEP as our daily option. Risk assessments that capture primary and secondary exposure risks to prioritize for PrEP is really only one element that increases uptake and use. Estimate numbers of those to be on PrEP are not calculated to take into consideration the ready, willing, and able. And if we want to increase demand, uptake, and continuation, we need more options beyond daily oral PrEP. Options are there: event-driven PrEP for MSM, dapivirine ring for adolescent girls, young women, the women population. So let's quickly act on them, which I think we'll see a better uptake from. We'll see more ready, willing, and able. And we just need more options. Running out of time. So just to kind of summarize some basic takeaways, risk assessments, are possible to be run. We can ask questions well to get a clear, distinct high, medium, and low segmentation. And we can show that segmenting high-risk populations into PrEP can lead to better uptake and ultimately better use over time. And ultimately, it are those who are at most risk of being infected that really should, understand their risk more and be on PrEP. Anyway, thank you for that.
Thank you so much. Actually, let's just leave Andy's last slide there up for a moment while we have so we don't have any questions in the chat. I'm kind of astounded, but please feel free to put questions in the chat if you'd like to ask our speaker something. But we do have a moment here, and I just wanted to get some reflection on the link between HIV testing and PrEP. So screening for HIV testing and screening for PrEP. And, in some cases, if we do both of those, it's duplicative. How can we combine them? And I think we saw some of that in what you presented, Andy, but I just wondered if you could reflect a little bit on the potential for combining HIV testing and PrEP screening, and then maybe Rachel could also reflect on that.
Yeah, for me, I think a lot of countries, when they started PrEP programming, thought they needed some special, risk tool to really identify what that was for people being eligible. And I think as Rachel had said earlier, a lot of the thoughts was about costing, and we only have so much PrEP that we have to really find those at highest risk. And I think that conversation around risk assessment tools for starting PrEP actually led to programs really trying to better understand what they're capturing for risk assessment tools for testing. And I think in this past year, we've seen those two types of assessments come together. So if you're at risk, you're at risk. And you use the same kind of questions, dialogues, and answers to really look at providing either one or both of those services. Yeah.
Thank you.
Yes. Yeah. Just to add, there is a lot of overlap, but there's a lot of difference as well. I think, for testing, of course, so much of the dialogue over the past couple of years is we must be much more efficient about testing way too often and way too many. And I think, some of that's been targets. And the ways we've implemented PrEP, and we've put where we've testing and where we've put services. There are some very simple things that you can do for testing, and that's really just ask us when did you last have a test, and something that isn't necessarily involved particularly with behaviors. Just a very simple thing to stop some of this really frequent testing of negative populations, because when you start again to complicate access to testing, which is a very, very cheap intervention, you are likely to put people off, exclude people, make it much more complicated for providers. Whereas the PrEP, the screening for PrEP, it's not necessarily only you know, about risk. It's about what, as I think, as Andy's just said, it's about what works for that individual. You may be, you know, maybe as high a risk for HIV, but maybe perhaps not for you. Maybe other things are. So, you know, it's not nearly so binary.
Thank you for that. We do have a question. So some of the questions are coming to all panelists. If, just for future reference, if you could select the arrow and select all panelists and attendees, then the attendees can also see the questions. There's a question to clarify the difference between the primary and secondary exposure, Andy. Risk.
Yeah.
Exposure.
Yeah, so, you know, it was really thinking about, you know, when we do a risk assessment, we're assessing that, you know, people are having unprotected sex or using or sharing needles if they're injection drug users. And that the exposure is about, the primary exposure is like where HIV enters the body. Secondary is behaviors that, let's say, substance use, abuse, and addiction that put you in a space of vulnerability that would lead to then eventually not using a condom or sharing a needle where then HIV enters the body. So, you know, we're often screening for, you know, when's the last time you used a condom? Did you use one? Was there an exposure? Have you shared needles? But we don't quite get or have time in many ways or programming to really get into those kind of secondary elements of people's lives that make them vulnerable. And you know, the idea is in unpacking those vulnerabilities, there is a prevention in that in and of itself. And so it's really understanding when we're unpacking the vulnerabilities, these secondary unpacking the vulnerabilities, we're really trying to gauge where somebody is so vulnerable that they really should think about going on something like PrEP, or is the vulnerability something we can, you know, talk through and provide other services to help them get past so that primary risk of the exposure goes away. And that's, yeah, so that's how I really tried to look at those two.
Great, very helpful. Thank you, Andy. I just want to note that our colleague from Lesotho sent us a message here saying that Lesotho is working on PrEP prioritization demand creation strategy to increase high retention on PrEP through the RAST. We obviously don't have a presentation on that today, but would love to have more information on that we could include in the resource sheet. We will be sending out all of these, a link to all of these presentations, as well as a resource sheet after this webinar. And so I think we'll move on to our next speaker, who is Joseph Marungu from Zimbabwe. Over to you, Joseph.
Thank you, Christine. Hello, everyone. Just to thank the organizers for this opportunity to share our experiences from Zimbabwe. So I'll talk about our findings and recommendations from a test and prevent study that we conducted here in Zimbabwe, mainly focusing on the issues related to the topic that we are discussing today. That's the risk assessment and screening process. Next slide, please. So in Zimbabwe, we adopted the WHO guidelines in 2016 and included PrEP as part of combination HIV prevention. And at that time, we're also emphasizing a lot on the revitalization of HIV prevention in the country. So we subsequently updated our guidelines and they include oral PrEP. I just want to emphasize that according to the national guidelines, PrEP will be made available to all individuals who are HIV negative and are at substantial risk of HIV infection after individual risk assessment. So the risk assessment is one of the 4 mandatory activities that have to be carried out before initiating a person on PrEP. The other three include the HIV test, ruling out acute HIV infection is the third one. And the fourth one is adherence counseling. The guidelines also include a longer list of practical questions that have to be asked just to refine and qualify the risk. We also note that the same questions should not be used to ration or exclude people from accessing PrEP. Next slide, please. So since 2016, we have seen a progressive increase and scale up of PrEP across the country. At this point in time, we have over 17,000 initiation in the country, and PrEP is available in most of the districts. As part of the process, clients have to be tested for HIV. And within the HTS program, we do have the HTS Screening Tool, which is administered to all clients seeking services at a facility. And the main purpose is to identify clients eligible for HIV testing in the hope of making the process more efficient and also cost effective. So a client is considered eligible for testing if he or she is found to be experiencing poor health, considers him or herself to be at risk, but also has a history of STIs and an HIV positive partner. Next slide, please. On the PrEP side, we have a different risk assessment and screening tool included in the national guidelines. This is then administered to determine whether a client should be offered PrEP or not. But it also has additional questions that might then lead to a client being offered PEP instead of PrEP, or be managed as a case of acute HIV infection. It is administered to clients who are testing HIV negative, and like I highlighted earlier on, it's mandatory before PrEP initiation, but also for subsequent resupplies and follow-up, clients are supposed to be assessed as well and receive risk reduction counseling. So based on these two, clients are eligible for PrEP if they have two or more partners, have engaged in condomless sex, a history of STIs, and also a history of an HIV positive or a non-HIV status. So you find that there's an overlap with the HTS screening tool that I talked about earlier in terms of the STIs and the HIV status of the partner, but also a difference in terms of the other questions and also the period we look at. So on the PrEP, the tool focuses on 6 months prior to the assessment, whilst the HTS tool is looking at 3 months. Next slide, please. So based on the national guidelines, we conducted a study which we were calling a test and prevent study, more or less similar to the test and treat concept for those that are testing HIV positive. In that we were in the study, we're aiming to make sure that all clients testing negative would receive one or more of the HIV testing, HIV prevention strategies in the national combination HIV prevention basket. So the goal of the study was just to produce evidence about the test and prevent intervention. We were using mixed methods, including conducting interviews among providers and clients, and the interventions were consistent with the national guidelines. In that we were making sure that all clients testing negative had to be assessed and then receive counseling and a referral to PrEP or any of the other preferred HIV prevention strategies. And then as part of the follow-up, we're also using different strategies, including reminder messages for clients to complete referrals or follow-up appointments. Next slide, please. So I'll just highlight some of the results from the study and focus more on the risk assessment process. So across the 16 facilities that participated in the study over the 3-month period, we had over 6,500 clients who were tested, of which the majority tested HIV negative. However, we noted that about 40% of those testing negative were not screened for PrEP eligibility. And I'll talk more about some of the reasons that we picked up in terms of why such a huge number of clients testing negative were not screened. And then after screening, we only 6% of those testing HIV negative were deemed eligible for PrEP following the risk assessment. And the majority of those, about 80%, were then actually initiated on PrEP. So we picked up that there was a disconnect between the results of the adult screening tool, which picked up that over 6,500 of the clients were at risk and needed testing. And what we picked up from the risk assessment process. So 94% of clients were considered to be at risk based on the screening tool, but not at risk based on the risk assessment and screening tool. And one of the feedback that we got from the providers was that adhering too strictly to the questions defined in the risk assessment tool could lead to lack of identification of at-risk clients, and I'll talk a bit more about that in the next slide, please. So we explored why clients were not screened, and some of the issues that came up were related to the competence of the providers to conduct the risk assessment and other follow-up tasks. So not every health worker was trained, and in the event that the trained cadres were not available, then most of the clients who were attending the facility on that particular day would not be screened. Then heavy workload was also another contributing factor, because when there were a lot of clients, they tended to focus on other services than the risk assessment. And along with that, the challenge of then completing the screening tool for the clients was something that was linked to the heavy workload. I think as indicated by Andy, there were also issues from both the providers and the clients not being comfortable to go through some of the sensitive questions around sexual orientation and activities, which led to clients not being screened. We also picked up that providers at times purposefully avoided screening clients because of the perceived duplication with the HTS screening processes. But we also noted that at times when the providers felt that a client was not at risk, then that client would then not go through a process of screening and linkage to follow-up services. Next slide, please. Yeah, so based on these findings, we noted that there was need to make sure that we build the capacity of the providers to conduct the screening and counseling for PrEP, but also in the same process make sure that we address the discomfort and bias in discussing risk behaviors, and also encouraging the providers to administer it in a more conversational manner, including the use of local languages instead of the rigid and structured way in which the screening tool is designed. There's also a need for further refinement of the risk assessment tool to address some of the sensitive questions as well. The HTS screening tool is currently being evaluated, but I'm happy to say that it has also been modified. We have an electronic version that feeds into the National Electronic Health Records system that's being rolled out, and there are also discussions around how to streamline the process between the HTS screening and the risk assessment, given that there's an overlap in terms of some of the questions that are asked. We also need to provide mentorship and support for the providers to be more compliant with the national guidelines, especially where we talk about the screening process and these questions are not being used to ration or exclude people from accessing PrEP. Thank you very much. Next slide, please. Yeah, just to acknowledge my colleagues and the other team members that contributed to the study and this presentation. Thank you.
Thank you so much, Joseph. That was terrific. I don't have any questions in the chat, so I think we're going to continue on to hear some reflections from our colleagues in Eswatini, South Africa, and Zimbabwe. So we can move on. So I just want to remind you of who our panelists are: Gertrude Nkube from Zimbabwe, Cindy Matse from Eswatini, and Hasina Subadar from South Africa. All of these three women have been really leaders in the policymaking space around PrEP in their countries, and so we look forward to hearing from them. There'll be a few slides for Hasina, but otherwise this is just a conversation. So I'm going to go to Gertrude first and just ask you to share some of your reflections on the experience in Zimbabwe with risk assessment for PrEP, any challenges or solutions that you'd like to discuss with the group.
Thank you so much, Christine. Good morning and good afternoon, everyone. And thank you so much for being given this opportunity, maybe to share the experiences. But Joseph has made my life easier because of the study which they did on test and prevent. So most of the things which Joseph has actually highlighted are the things which have actually come to us as Ministry of Health and which we are actually seeing on the ground, which is actually happening. And maybe, like Joseph said, we actually started PrEP in 2016 as a phased-up approach on a demonstration project, and we are almost now to national scale. So with this, this screening tool is actually mandatory for anyone who is actually at substantial risk of getting PrEP, and those were the questions which actually Joseph looked at. And with the recommendations which have come up from the test and prevent screening tool, Ministry is actually in the process of coming up with an operational plan for pre-exposure prophylaxis, because the one which we had actually expired in 2020. So with the operational plan, which is actually coming, we are actually looking at reviewing the screening tool. The issues of workload for the service providers, it came out in the study, and when we go out and see those things, the service providers, they actually look at what they're saying with PrEP and with that screening tool. There's a lot of information and there's a lot of questions which they are actually asking. And as a result, at times, they are not actually providing quality services. They will actually skip some of the questions, especially in high volume areas. So with this, actually, we've actually looked at this and then to say, how best can we actually address this? We are actually in the process of addressing to review that screening tool, especially after the study which was done in collaboration with ministry, with Pangaea. And we've gone even ahead to have some, like when we go out for mentorship, and then we have some survey with service providers. We have some surveys with clients as well to tell us what they feel about the screening tool. Clients and service providers overall express an appreciation for the importance of the screening tool before one is enrolled or resupplied with pre-exposure prophylaxis, oral pre-exposure prophylaxis. But what needs is to do, we need to look at the logistics. Like already Joseph alluded to the fact that maybe the HTS screening tool is now within our electronic records, health records. But if you look at the PrEP screening tool, it's still not. So we're actually looking at that to say all this paperwork on this PrEP screening tool, maybe if it's electronic, then it will actually be looking at that. And then there are the issues on the increase of workload. I think if it's now the electronic record and the electronic records, it will actually assist us with that. There was even a comment from the service provider who said the paper-based tool is not really user-friendly. Due to the length of the tool, some nurses in high-volume facilities usually skip some questions to make sure they attend to everyone. So this, like I said, is it really the screening tool? It raises the question of, is this screening tool which you are using really effective? So as ministry, we are actually looking at when we are coming up with the new implementation plan, as well as revising our operational service delivery manual to actually address these issues. And then the other comments as well from the clients themselves. This was an adolescent girl and young woman in one district who said, most of the nurses are older and don't understand our situation. So it's difficult to share our sexual issues. It's better to use our peers in the community. So this actually has come out from the clients themselves, especially the adolescent girls and young women. And I think when Rachel was presenting, actually alluded to such kind of sensitive questions, especially when we are faced with an older nurse who is actually asking an adolescent girl, because most in our health facilities, it will be those nurses who are actually working on that. So we've actually looked at all those things, and we are actually trying to address, like we realized our screening tool when we adopted it from WHO, and we took it as it is, and as Joseph has said, is actually mandatory. I think what needs to be done is validation of the screening tool, so that the screening tool is actually those who are at risk, they are actually screened to get the services, so that it doesn't actually screen out those who are not at risk. So we are actually looking at validation of the screening tool as ministry, and for the PrEP screening tool. We have, like Joseph has already alluded to, we have the HIV testing screening tool. And 2 weeks ago, I was actually in a meeting where we were saying, if we are looking at PrEP indicators, we are saying how many people are supposed to be initiated. What is our denominator? And the denominator was those who are eligible. And then they were saying, where do we get those who are eligible? They said from the HTS register, you get that. And then they say, but in the PrEP register as well, they say those who are eligible initiated on PrEP. How should we balance the two? It's not duplication of, so with what we have done and what the findings which are coming up, we're actually looking at the validation of the HTS screening tool. And again, we'll actually be looking at the validation of the PrEP screening tool. We have an on-service delivery manual, which actually talks about that. And we are actually looking at how best our own service delivery manual, which is in a job aid form, can actually be able to help the nurses, help to actually ask the right questions and all that. And some of the recommendations which have come up as providers as we train our health workers is actually to look at how best we can put risk assessment process could be started at community level with assistance from peer counselors and community cadres. Because most of the time, these people are actually mobilized by peers and all that. So especially the adolescent girl who said, I'm in front of these older nurses who are. So we're actually looking at, maybe we come up with something which at community level, the peer educators can actually look at. And then we have actually as a country to say, as we are revising our tools, like we are coming up with the PrEP implementation plan, we are coming up with the revisiting our training manuals, and we are actually coming up with looking at the screening tool as well as we go forward, as we scale up pre-exposure prophylaxis. We need even to include in that screening tool aspects of PrEP adherence and safe sex as part of risk assessment tool for that. And what we are even looking at as a country right now, we are actually looking at, when you talk of combination prevention, we are actually looking at integration of services. And there's a pilot which we are actually doing with WHO, where we are actually looking at one-stop shop of services. Like this one is one-stop shop of services for family planning. So we are actually, and we are giving PrEP there and family planning and HIV self-testing. So we are actually looking at coming up with counseling messages or counseling manuals, which are really sensitive to the needs of our clients and all that. And with that, within that counseling messages, we are actually looking at how best it can improve, like the questions, which most of our clients said at times the questions, they are not comfortable in answering the questions in front of that, and which leads to misclassification of who is at risk and who is not at risk. So those are the plans for 2021 for us, because this study was done sometime last year, and we were looking our PrEP operational plan expired sometime last year. So we are in the process of reviewing and looking at those things, which is actually the recommendations from the study and the recommendations from our clients, as well as from our service providers. Thank you so much for listening.
Thank you so much, Gertrude. You touched on so many important points. It's hard to even decide what to comment on, but I did want to highlight, you mentioned this engagement with the end users and providers, and I just think that's so important as from the policy side, we think about these tools, but actually getting that input from the users of the tools is essential. And then really your last point about integration too, and thinking about as we move to having more HIV prevention products and certain options available, as we look at more differentiated service delivery models, how do we make this screening simpler and more effective? Really great points. There are a lot of comments and questions in the chat, but I'm going to move forward with hearing from Cindy and Hasina, and then we'll go back to the chat questions. Cindy, would love to hear some from you, from your experience in Eswatini.
Good morning, good afternoon. Thank you, Kristen. I'll be sharing our experience as Eswatini. In implementing PrEP, we started in conducting demonstration projects from 2017 up to 2019, and then we scaled up from then up to date using a phase approach. So part of the demonstration projects, we did develop a risk assessment per the guidance of WHO. And that risk assessment, it was a tool. The healthcare workers, mainly it was the doctors and nurses, they were expected to record the responses from their clients. And it was meant to identify the HIV risk behavior, also to identify clients if they belong to any priority populations. We're also collecting some demographic information, and we're also assessing for contraindication for or eligibility to be enrolled. So this tool was not meant to exclude anyone from accessing PrEP, but to identify those that can benefit from PrEP. So when we, at the end of the demonstration project, when we evaluate based on the feedback from the healthcare workers, they complained that it was too comprehensive, it was time consuming, and at times there were some fields that were not filled. And what we also observed during the demonstration projects, the questions that were there trying to identify clients, especially the key populations, the healthcare workers, they were not at ease to ask those questions. So half the time they were not even filling that information around those questions. And also at that time, we had two screening tools, the one for HTS and also for PrEP. And they also complained that we were using both, they had to use both a screening tool to clients. And then based on the recommendations that they made, we did simplify the risk assessment. And to reduce the recording, we then developed a job aid, which a set of questions, which was only the identifying the risk behavior of the client. And we also maintained the questions that were identifying clients if they belong to a certain priority population. And on the other side of the job aid, it was the eligibility criteria. So it was just a checklist to guide our healthcare workers when they engage with clients. And this job aid was positioned or placed in all the entry point within a facility, even those that were at community level, like our mobile unit, because they are also providing PrEP. So what we realized when we also evaluate this, yes, the healthcare workers, they were happy that they were not required to record anything. And the questions, they were fewer because we had about 7 questions in that job aid. But then we realized that in the different departments, it was not used. The expectation was that they can do a risk assessment in any department whenever they see a client, and then they can refer the client to the HTS department for testing in case they're interested. And we have developed an intra-facility referral form, which they were supposed to use to avoid asking the patient or doing the risk assessment several times in the different departments. But then we realized that the healthcare workers, especially the clinicians, they never use the job aid. It was not largely used in the department. And also even the intra-facility, it was not used. It was largely used, the job aid, it was largely used by the HTS counselors. And they were also meant to use the HTS one. So they were still using the two. And then when we evaluate, they also complained that they are now using a lot of risk assessment. Can we match the two? And then recently, we then sat down with the HTS team and we tried to modify our risk assessment. So as we speak as a country, we now have one risk assessment which has been integrated into the HTS register with the question, because most of the questions were overlapping from PrEP and the STS. So it's now very easy for them to use, but then it's sitting where HTS is done. We've developed a job aid again with all the prevention methods that can be used by the other departments to engage clients whenever they see them. But then where there is HTS, because we know that we're doing targeted and HTS is done in certain departments within facilities. So we believe that the risk assessment, they are using the risk assessment when they're engaging the clients for testing and then to see if they can also benefit from PrEP. So ever since we started implementing this, we've seen, yes, a progress, and we are able also with this, because we are recording now all the processes for a client from testing up to when they are initiated. We're able to track our PrEP cascade because we have the information within the register. So this is where as a country we are, and we hope it's going to work. But then we are also anticipating problems, especially because of the shrinking of the support from our partners, as we'll be having our healthcare workers, especially the nurses, doing the testing, and then now have to also test for PrEP and initiating clients. We might have some hiccups because now it was easy because it was the HTS counselors who were doing all the work, especially engaging the clients, and they were able to even provide more counseling because we've also trained them on counseling on PrEP. So those are the things that we are anticipating moving forward, but we are happy that we've tried to compress this So we might have the challenges, but it's not like when we have this different risk assessment. I think the nurses, they were not going to be happy at all. I know even now they are going to complain when things go back to the nurses, as we are having the challenges of the government now absorbing the HTS, which is likely not possible. So some facilities will expect the nurses to be doing all the work that was done by the HTS counselor. So thank you very much.
Thank you so much, Cindy. I think this is a great example of sort of the different progression, you know, starting with the two separate tools, then going to a job aid, then going to an integrated HTS and prevention screening approach, and yet still the challenges remain with provider buy-in and engagement and capacity to move these forward. So thank you for that. We're going to move on to Hasina Subadar from the National Department of Health in South Africa, and Hasina does have 2 slides to share with her points. So over to you, Hasina.
Thank you. Thank you to the organizers for inviting me, and thank you to all of you for availing yourself for this discussion. I know it's quite late in the day, especially for those in the time zone that we are in. Just to say that from South Africa, you know, we started implementing PrEP since 2016. And of course, we also, like everybody else, started using a phased approach. And we started with those populations that were at greatest risk, and that was initially the sex workers, but gradually moved on to men who have sex with men, to university campus students, and then we moved on to offering PrEP to adolescent girls and young women. As we speak right now, we have and started with a massive scale up throughout the country, offering PrEP at all of our public health facilities. However, COVID overtook our very sort of well thought through and planned approach to scaling up PrEP in all of our public facilities. And so currently what we are working on is to actually look at how we can make sure that where we did not succeed in getting PrEP up and running, how we're going to get that over the next few months. Having said that, I think what was really important, and you know, at the very beginning, we had produced guidelines, we had produced IEC materials, we had produced demand generation materials. And one of the things that we did across the board, across the entire country, and whether it was for any of the populations, the messaging was always very clear. And within that, I think the issue of identifying those that are most vulnerable was also quite clear. And so what we did was, as part of the guideline, had key questions that were included in the PrEP guidelines for healthcare providers that were assessing a client who was HIV negative, to make a decision as to whether this person should be offered PrEP, or to initiate the discussion on PrEP more rather than offering PrEP. And this then progressed, and as we went along, and what you see on the screen right now was we developed a counseling job aid with the assistance of our various partners that have been implementing PrEP, with the guidance from the information we received from the different implementing sites. I think what became quite clear was, and I saw in the chat, somebody had indicated that the pressure for reaching your targets really pushed people into offering everybody PrEP. And as a result, you didn't really get those that were really going to benefit from PrEP that were offered PrEP, and that resulted in a lot of dropouts. So this job aid that we have and that you see on the screen was really to identify and to assist the counselors who in South Africa, most of our counselors that are doing the HTS are lay counselors with some limited amount of training. And so this is guidance to them to say, if somebody tests HIV negative, how do you broach the subject of PrEP for that particular individual? And so literally, if you look at it in that job aid, it starts off with the pre-test information, looking at the HIV test, looking at the post-test counseling, and then looking at assessing your client's level of risk for getting HIV. And so we've just put very simple questions there. And if you look at the questions that are on that job aid, and we can share that with you, so I don't need to go into the detail, but really to actually look at, does a person respond yes to any one of these? But the other caveat in all of this is that somebody who tests negative or who comes into your health service asking for PrEP, they don't have to answer yes to any of these questions. They may choose not to answer any of these questions and say, we want PrEP. And in that case, the person is, the bloods are taken and whatever else needs to be done is conducted. And if they meet the requirements, they are then given PrEP. And I think this is quite important to indicate that, we do not want, and this is quite important, especially if we look at what's happening amongst young people who indicate that when they do arrive at a health service and ask for contraception, they have nurses who are older than them and saying, but you've got no business to be sexually active, and why do you want contraceptive, and get scolded and sent away. And we want to avoid that kind of situation. We want anybody to feel comfortable to walk into a facility and ask for something. And that leads us to the next tool that we developed. And if we could just change the slide. And we have a Mobi site called BeWise in South Africa that we use for reaching young people. And most recently, in about August, September last year, we revamped this Mobi site and included and tried to make it much more user-friendly for our young people, so that we've got tools that they can actually use to make decisions themselves. And if you look at this particular tool that's there, is that it's a tool called Is PrEP for Me? And if they say, if this is something that they're interested in, if they've had an HIV test, so if they press enter, the first question is, are you having sex, or are you thinking about starting a sexual relationship? And then it moves on to the next question. If it says yes, do you know your HIV status? If they say yes, they're sexually active, do they know their HIV status? And if they do know their HIV status and says, I am HIV negative, it would then move them to the next, do you want to know all about your options about staying HIV negative? And if yes, they then move down, and this is where the risk assessment comes in. And I think this is quite important, especially with young people. How do we develop agency in them to be able to identify their own level of risk, rather than us healthcare providers deciding for them whether they are at risk or not. And this is particularly important in the context of PrEP, because if we talk about PrEP, we always say PrEP is not a lifelong intervention. You take it during seasons of risk, and that may change in your during the course of your sexual journey or your life, and then you can make a decision as to whether you want to stay on PrEP or stop it. And I think this is why it is so important that we develop the capacity, whether it is a young woman or anybody that's on PrEP for that matter. We need to be able to get them to work out whether they are at risk or not, and to make those decisions. The chances of people remaining on PrEP or going off PrEP because they're not at risk is much better if it's managed by the individual themselves. And so if they say yes to any of these, they can then say PrEP is a possibility, a great option for you. right? And if they are interested in PrEP, and there's a clinic finder that they can click on where they can put in their geographic location, and it will identify where PrEP is offered and where they could potentially go for PrEP. We are hoping that once we develop this tool further, is to actually, because there is a chatbot associated with this, so they can have a conversation with a chatbot, but there's also a online self-help, a dial-in call center that they could dial in and chat to somebody if they need to. They could chat to an expert, and depending on what their decision is, they will then present at a clinic and say, I want PrEP. And if you develop such a process and the person has already gone through this risk assessment themselves, is there a need to actually then ask them all of these questions all over again? And also it reduces the time that the healthcare provider has to spend with an individual, because this individual has already found out about PrEP, decided I want to have PrEP, and then moving on. So I think these are tools that will be really useful to actually look at whether we can develop these further and make sure that they are much more widely available and accessible to most PrEP users. I'll stop here, but I think just the one thing that I would just like to add, and that is that, when we talk about eligibility versus, sort of whether somebody would benefit from PrEP, I mean, technically, every person that is HIV negative is eligible for PrEP. Provided they don't have any allergic reactions to the drugs that they will be taking or whatever. But whether they would benefit from it or not is what we're trying to assess, and whether they will actually want to continue. The other point that is really important in all of this is that we are getting more and more new biomedical products that are coming on the market. And so the choice is quite important, where people can actually make these choices as to what it is that would work best for them. Thank you.
Thank you so much, Haseen. And I think you raised such a critical point at the end there, which is that this is, now is the time that we really need to think about how we can optimize our approach with oral PrEP, because we want to do it well with these new products coming into the market. With hopefully expansion of event-driven PrEP, which will require its own whole set of counseling and guidance. Hopefully the addition of the dapivirine vaginal ring for women. Hopefully in a year or two more, the addition of injectable cabotegravir as well. So whatever we can do now to improve the efficiency and effectiveness of our approach to screening people in or out of PrEP is really critical. I really like also your framing about really shifting the conversation shifting the conversation from what happens in the clinic to what happens in the community prior to the client coming into the clinic. So the client is actually informed and enabled to come in with information and a sense of what they want. Such an important point. We don't have a lot of time. There's so many comments and questions, and we will respond to all of these in the resource sheet that we sent out afterwards. But I thought maybe we should just touch on one issue that came up around providers. So just a lot of comments about, risk assessment and providers, and how they play a potential gatekeeper role, and how some of the examples even that you've described. Some of the work you've described, Hasina, Gertrude, and Cindy, is trying to get away from that so that they are less of a barrier. But I just wonder if you would like to comment a little bit more on how do we do more to increase the skill and confidence among PrEP providers in this space, and any other thoughts you have. open it to either Gertrude, Hasina, or Cindy, or anyone else in the panel room is welcome to respond.
Can I make this is Andy, so I just thought of a very funny way of thinking about that. So, you know, I think of going to get PrEP from a clinic, like going to buy condoms at a pharmacy. I don't want the pharmacist to show me how to use the condoms and ask me a bunch of questions about them, but I would, you know, but from a peer, that would be okay, and that might be really helpful and useful. So I think, you know, really unpacking how we kind of talk about risk and ask these kind of questions, you know, we really do have to look at the two kind of different approaches. One is supportive, I think, with more peer, and the clinical would be something that would be more of a barrier. And I think we often try to lump it all together into, here's how you have that conversation. But I think it's really unpacking what needs to be said within a clinical context and what could we use a more peer program to be able to do that conversation. That'd be my thought. Sorry for the funny condom reference, but yeah.
Maybe as well to add, I think our service providers as well, they need, I've heard of motivational counseling, where service providers are friendly, and when they are actually asking questions, because some of the questions, they are sort of like direct questions, which actually can even be asked like as if I'm having a conversation with that person. So I'm looking at really service providers, especially when they are encountering the adolescent girls or the key populations, they need actually to be capacitated to be adolescent friendly, and the way even they ask questions. So I think those are the areas as well. But what I found at times is a challenge is maybe you will be having, we'll train them to do the services, but we don't follow it up with mentoring as well. And at times it's actually because of funding, which is a challenge at times when we are introducing these new activities. I can only have one training for them and then mentoring, fair and fine, but maybe come back again, maybe the following year and all that. So I'm just looking at, I think, the continuous mentoring, capacity building, and the change in the training, where we are actually looking at motivational counseling and all that. Thank you. Over.
Thank you, Gertrude and Andy. Those were both excellent points. And yes, we need more investment in this area. Looking at the time, and I think we're going to need to wrap here, I just do want to check with the panelists. Does anyone have a final comment they'd like to share?
This is Rachel here, and I just want to say it's always the best comments and experience are always from the field. So Cindy, Gertrude, Hasina, absolutely fantastic presentations and really, really rich information coming from that. And I think, you know, I think two messages for me, and it's all about empowerment of people and knowledge. And I think, you know, having something online, having something that people can assess themselves, think about issues themselves without being, you know, having to divulge all these things to others, is really, really a great thing. And then really trying to reframe from a screening, a risk assessment, to more of a conversation. I think, you know, that for me would be a powerful way ahead.
Great. Hasina?
Christine, yes, thank you. There's been quite a few things on the chat about the tools, and I've just put them. We've got 3 platforms that you could access. The one is the BeWise platform, and I've put the link to that. And there's on the BWise platform, if you go to the toolbox, you'll see the PrEP tool on there. And there's also a lot of information, but framed in a way that is accessible to young people. And the second we have is an online training program. And on there we have also a video of an interview between a client and a clinician. And I think it's useful, especially viewing how other people approach it. It may be useful to actually look at that. And then the third resource is the website that we have, and all of the tools that we have, the job aids and everything else is on the, can be accessed through the website as well. Thank you.
Thank you. And I know there were requests for templates, so I would request that, we'll ask from our panelists to provide what they think are best examples and best practices, similar to what Hasina just showed and shared. But if there are others in the audience who have some best practices that they would like to share, please do send them to us. And you can just respond, I believe, to the registration email you have. And we are going to put together this resource sheet. It usually takes us a week or two to get it out, but it's quite comprehensive, and we'll have links to everything and responses to the questions we didn't get to. So just a really incredible thank you to Andy and Rachel and Joseph, Gertrude, Hasina, and Cindy. This was a really terrific session, very rich, much to think about. We do have these webinars every month. The next webinar in February will be focusing on what we can learn from two studies, Power and Search, on actual implementation of PrEP and PrEP delivery. And then we'll talk in March about PrEP continuation. We do welcome your suggestions. If there are hot topics in PrEP that you want to discuss in this forum, please do send them to us as well, as we will be mapping out the next few sessions in the coming months. That's all. What's the next slide, Casey? I wasn't quite sure. Yeah, here's the registration link. And thank you, everyone. Have a wonderful day and evening.